Hello, my name is Madeline Fitzpatrick. I'm a third-year resident at the University of Tennessee in Nashville, interested in hematology oncology. My case today is about a previously healthy 30-year-old who presented with abdominal pain and was found to have an exceedingly rare and aggressive subtype of diffuse large B-cell lymphoma called plasmablastic lymphoma, or PBL for short. His labs on initial presentation were unremarkable, except for a positive HIV screening test. A CT of the abdomen was obtained, which revealed a large rectal mass that can be seen in coronal and axial views on the bottom left hand of my poster. The mass was biopsied and revealed plasmablastic lymphoma. This is a difficult diagnosis to make, given that histologically, PBL has features of B cell and plasma cell neoplasms, and its immunophenotype is similar to plasma cell neoplasms. Figure 1 at the top middle of the poster shows the colonic mucosa on the left and the same picture with higher magnification on the right. You can see the large malignant cells. They have round nuclei, prominent nucleoli, and abundant cytoplasm. Figure 2 under that reveals CD8 immunohistochemical positivity on the left and Epstein-Barr virus encoded DNA positivity on the right. And lastly, figure 3 on the bottom reveals an overabundance of kappa light chain staining on the left and a normal lambda light chain staining on the right, indicating plasma cell differentiation. Back to our case, after the diagnosis of PBL was made, our patient was discharged with close oncology follow-up 2 weeks later. He arrived to his appointment and looked awful. His labs revealed an elevated uric acid, elevated creatinine, and he was admitted urgently for tumor lysis syndrome. A renal ultrasound revealed bilateral hydronephrosis due to tumor compression of his ureters, and he required bilateral percutaneous stent placement. 10 days later, as he was preparing for discharge, his abdominal pain acutely worsened, and a repeat CT of the abdomen pelvis revealed free air. His bowel had indeed perforated, and this required colectomy and ostomy placement. His treatment was delayed by these setbacks, so chemotherapy was started while he was inpatient. This was started with bortezomib and dose-adjusted etoposide, prednisone, vincristine, cyclophosphamide, and doxorubicin, or VEPOC for short. I saw him earlier this week in clinic. He looks great. He's gained a lot of weight and is even planning on going back to work soon. He has 2 more rounds of chemotherapy, and then we're planning for localized radiation therapy. So PBL was first described in 1997. It's seen most often in immunocompromised patients, either patients that are post-transplant or those infected with HIV. Given its rarity, there's really no standard of care chemotherapy regimen for PBL. The prognosis is quite poor. Median survival is less than 3 months if there's no treatment and around 14 months with treatment. However, adding bortezomib, which is a proteasome inhibitor that's usually used to treat multiple myeloma, to the EPOC regimen, has been shown to induce long-term survival. A small case series of 16 patients showed a 5-year survival rate of 65% with this regimen. In addition, patients with PBL may benefit even more with radiation therapy. This case demonstrates how a thorough workup on a patient with a very common complaint like abdominal pain can reveal life-altering diagnoses. Our patient walked into our waiting room of the ER with no medical history and was found to have AIDS and an aggressive form of lymphoma. Despite his complicated hospital course and the setbacks he faced, with aggressive multi-agent chemotherapy and consolidation radiation therapy, it could be possible for him to achieve long-term survival. Thank you so much for your time and attention today.